It's a pleasure to be here. Thank you very much. I've been asked to spend the next 15 minutes discussing the potential role of intraortic balloon pump counterpulsation in patients with cardiogenic shock. I have no disclosures relevant to this topic. I do have one caveat. The limited data that we'll talk about really focuses on patients that have cardiogenic shock complicating an acute myocardial infarction, and I'm really going to limit my comments to that patient subset. So I was assigned a topic to support the underdog, and the title of the topic I was assigned was the optimal support platform in shock. Let's not forget the intraortic balloon pump. Now, your knee-jerk reaction when you get assigned a topic like that is, well, actually, let's forget the aortic balloon pump, right? I mean, we've heard about the ECMO. We're going to hear about tandem heart. We're going to hear about Impella. We're going to hear about topics and devices that provide a lot more hemodynamic support. And the fact is that there's been a lot of very highly publicized data over the past several years that really suggests that the intraortic balloon pump is not the ideal support platform for the majority of patients in cardiogenic shock. So the knee-jerk is to say, let's forget it and let's move on. But I think that the topic is a little bit more complicated. And what I hope to do is give you over the next 12 minutes a somewhat balanced and nuanced discussion of the potential role of intraortic balloon pump counterpulsation in cardiogenic shock complicating acute myocardial infarctions. So I'd like to start off, as all good shock talks do, with the pathophysiologic paradigm of cardiogenic shock. And really what I want to emphasize is that the only thing that we can really impact is cardiac output in the increased LV EDP, right? There's a whole cycle of things that are going on here that we have absolutely no therapies for. And so we focus on devices that can increase cardiac output and decrease the left ventricular end diastolic pressure. So therefore, it makes some sense to use devices that do that and do that relatively well. So how does the balloon pump stack up? So this is some animal data that looks at hemodynamic effect of intraortic balloon pump counterpulsation. So we see cardiac output, 4% increase in aortic pressure by 11 millimeters of mercury, increase in carotid artery flow by 8%, which is a marker of end organ perfusion, increase in diastolic coronary flow by 96%. The balloon pump does a great job at increasing diastolic pressure and therefore increasing coronary blood flow, and a very modest decrease in LV work. So the hemodynamic effects of intraortic balloon pump counterpulsation are modest at best, and you might suspect that its impact in cardiogenic shock might also be somewhat modest. I'd like to start with clinical data, the SHOCK trial. So as we all remember, the SHOCK trial was looking at patients with cardiogenic shock complicating an acute myocardial infarction. Patients were randomized to medical therapy versus revascularization. And what I want to point out is that 86% of patients in both arms, the revascularization arm and the medical therapy arm, 86% of the patients had balloon pumps in place. How did those patients do? Not very well. We know that in the revascularization arm, 47% of the patients died. In the medical therapy arm, 56% of the patients died. So about half the patients died, despite the fact that 86% of them had balloon pumps in place. Now, SHOCK trial was not designed to look at patients with balloon pump support and patients off balloon pump support, but I think that we can at least draw a conclusion that intraortic balloon pump counterpulsation is not a panacea, right? So it certainly did not reverse the shock state in most of these patients, and a lot of these patients died. So let's move on to more specific data with regards to balloon pumps. So this is the first bit of randomized data that we have. This is the Iabp SHOCK trial. This was a safety and feasibility trial. These were patients with myocardial infarctions complicated by cardiogenic shock. Patients were randomized to PCI plus balloon pump versus PCI alone. There were only 45 patients enrolled in this trial, so very small. And they looked at some surrogate endpoints. So if we look at the top right panel, we see cardiac index. We see there's really no difference in cardiac index in the patients on balloon pump support versus not on balloon pump support. We look at the bottom right, interleukin-6, patients on balloon pump support had higher levels of inflammatory markers, which is not necessarily what you want in the setting of a myocardial infarction with shock. We look at the bottom left panel, we see BNP. So patients on balloon pump support had overall lower levels of BNP over time, suggesting that the LV was unloaded to some degree. So we have a little bit of unloading, no change in cardiac index, increased inflammatory markers. There was no difference in mortality, although this was grossly underpowered to really demonstrate any difference in mortality. This really laid the groundwork for the Iabp FACC trial. This was a large randomized trial. There were 600 patients with, again, cardiogenic shock complicating acute myocardial infarctions. Patients were again randomly assigned to PCI plus balloon pump support versus PCI alone. The primary endpoint was 30-day mortality. There were some safety endpoints looking at bleeding, peripheral ischemia, sepsis, and stroke. So here's a summary slide for the results. If we look at safety, we look at things like sepsis, stroke, and peripheral ischemia. There was no statistically significant difference between the groups. So in general, placing the balloon pump under these circumstances was safe. But if we look at the primary endpoint, which was mortality at 30 days, there was no difference. So there was no benefit to PCI plus balloon pump versus PCI alone. So these are the survival curves. And the intra-aortic balloon pump showed no survival benefit in cardiogenic shock in this patient population. So this is the 30-day data. The 6-year data was published last year, and again, showed no mortality benefit. Right? So on the basis of primarily this data, the national and international guidelines reflect this in the use of intra-aortic balloon pump counterpulsation and cardiogenic shock. So the 213 ACC AHA guidelines give this a 2, it's actually a 2B recommendation. The use of intra-aortic balloon pump counterpulsation can be useful for patients with cardiogenic shock after STEMI who do not quickly stabilize with pharmacologic therapy. We look at the more recent European guidelines from 2017. They're a little bit stronger, and they actually give that a class 3 recommendation. So we have a large randomized trial that shows no significant benefit overall in patients with cardiogenic shock complicating an acute myocardial infarction. And we have at least the European guidelines that say for the general population that this is something that should not be used. All right? So I want to stop for a minute, and I want a little bit of audience participation. And I'd like to see a show of hands in the past 6 months, how many people have taken care of someone on a balloon pump? Right? Okay. So we're all either bad doctors, we work at bad institutions, we don't know what we're doing, or there's more to the picture, right? So let's delve a little bit deeper, and let's not forget the balloon pump, all right? So let's start off by looking at the medical therapy arm in the shock trial registry. So patients that were treated medically only, we can divide them up. And if we look at the patients that did not receive thrombolysis and did not get a balloon pump, those patients did horribly. So their mortality was 77%. Next box over, if you had a balloon pump with no thrombolytic therapy, you did much better just with the balloon pump alone. The patients that did the best were the patients that received thrombolytic therapy and intra-aortic balloon pump counterpulsation. So there's certainly a benefit to patients that are receiving thrombolytic therapy and non-mechanical revascularization to balloon pump counterpulsation. I think this is a very reasonable use for that device. But I want to get into something that is a little bit more interesting, which is looking at the shock trial, so both the trial and the registry data, and looking at survival by response to intra-aortic balloon pumps. So this is a little bit of a busy slide, so I want you to try to follow with me and just look along in blue. So we have the shock trial data patients, and we have the shock registry patients. And within that, there was a certain number of patients that primarily had LV dysfunction. So we're going to look at those patients. We're going to look at the patients that had primarily LV failure that had balloon pumps placed. There's a little trick to the shock trial data, and that is that the CRFs were modified part of the way through the trial to reflect response to balloon pump therapy. So the coordinators would go by 30 minutes after the balloon pumps were in place and indicate whether the patients were responding or not. So they were either complete responders, they had complete reversal of hypoperfusion, or they did not, all right? So we're going to look at the difference between the patients that responded at 30 minutes versus the patients that didn't respond in 30 minutes, okay? So this is a survival curve of the patients. This is the trial data. So this is 30-day survival for the patients that did not respond. So you put a balloon pump in, you come back 30 minutes later, and they still have findings of hypoperfusion. Those patients did very poorly. However, the patients that responded had very good survival at 30 days. So almost 70% survival in the patients that responded to balloon pump counterpulsation. So this is the trial data. This data is reflected also in the registry data, and this is also expanded out to 1 year. So the survival benefit is extended out to 1 year. So there is a subsegment of patients that correlates with what we do clinically, with what we see clinically. You see patients that respond to the balloon pump. That's why we use it. So when I try to summarize utility of balloon pump counterpulsation and AMI shock in the current era, it probably does have a limited role, but I would submit that there is a potential patient population that does well with balloon pump counterpulsation. And this is borne out in both the shock trial data, the registry data, and our day-to-day clinical practice. And it makes some sense, if this is your preference, to implant a balloon pump. But if you're going to do that, you should definitely reassess them within 30 minutes and make sure that the patients are responding. Now, we don't have any data to suggest that if they're not responding that you should escalate therapy, but it certainly makes sense, and it actually makes as much sense as virtually anything else that's going to be talked about today with regards to percutaneous support. There are a group of patients with AMA shock with thrombolysis without PCI. Those patients would likely benefit from balloon pump support. Remember that there was no survival benefit in the randomized shock trial, but that is the broad population, and there probably is a group of patients within that that would have benefited. And it's a class 2B to 3 recommendation in national and international recommendations. And I will stop there on time.
So I'll start the questioning. That was really fantastic. You listed the options of why people still use balloon pump. We're bad doctors, working at bad institutions, blah, blah, blah. I think there's one other kind of possibility global, which is that when we don't like the result of a randomized trial, we ignore it. So maybe that falls under being a bad doctor. But it is very difficult to stop people from using a device that they feel is working. So that is really a big challenge. And I just wonder why. I don't know if maybe some people would like to answer the question on the panel that use balloon pump. What is the rationale that you're thinking in your head that when you use a balloon pump, why do you use it in light of hard data saying that you shouldn't use it?
So I think the Iabp2 trial is a beautifully done trial. It's a pretty unique population. 50% of people have had a cardiac arrest. 30% have undergone hypothermia. There's a lot of non-cardiac morbidity and mortality in that group itself. I think when you're by the bedside and you take a population of patients in the CCU, there's definitely a population that does respond. I think you certainly see that. I think I'm all for the fact that if your sole intent is to increase cardiac output and stroke volume, the balloon pump is useless. It's not going to give you that. But at least in my clinical practice, I see people with combination of active ischemia, active MR, in whom placing the balloon pump, I'm not going to get another page the rest of the night. They're really calm and quiet. And I think that's what you see by the bedside. And I think that's what you're seeing in people around, it actually buys me some sleep, and it doesn't hurt my patient.
Based on the curves that you showed, responder versus non-responder to balloon pump and the survival, dramatic difference. I'll bet if you did a sample size calculation, you could prospectively, which is what we need, because you can hear the definition of what a responder is also retrospective in a sense. You could probably do a study with a relatively small number of patients. So that's something to think about, those of you who are still balloon pump believers. I think it really does. It's very easy to criticize the results of clinical trials, but people who have the capability should really consider doing clinical trials to show the opposite and prove that their algorithm is beneficial, because that helps the entire community.
So, sorry, Esther again. So as the advanced heart failure doc, sometimes I feel at these talks that we are kind of the ugly stepchild. But I think the entire population that has not been discussed here is the chronic heart failure population. There's actually an excellent publication from Columbia, I think you're on it, that looked at chronic heart failure patients in response to balloon pumps that showed very differing results. It was not a randomized trial. It was a cohort study of about 130 patients, but that they identified a very substantial portion that were actually super responders, which they defined, I believe, as more than 1 liter of improvement in cardiac output. And that was a substantial portion. And that actually the predictor of, this is a double negative, so forgive me, but a predictor of being a non-responder was having an ischemic myopathy, which kind of raises the question, are we using balloon pumps in the wrong population? And so far, we've only discussed acute MI. And from a chronic heart failure population, I don't think I've seen any data to say not to use a balloon pump, right? And in a routine, at least randomized control trial data of almost anything.
And as you know, I mean, in the heart failure community, balloon pumps are still used. And that is not inappropriate, because the trials did not show that it shouldn't be used there. But
so I just wanted to bring it up because we sometimes get forgotten. And I mean, anecdotally, for those of us who take care of these patients, we see this all the time of cardiac outputs responding quite beautifully in our chronic heart failure patient population. Again, just showing the different adaptations and how our patients are just different in so many different ways, other than the one line that just says etiology.
Shifting goalposts, we have specialized that always in cardiology. Anytime a trial is done, we always say something else is better or something newer has come. That is not new. Bottom line is, these trials, when done very rigorously, the first one he said was absolutely right, thrombolytic therapy response or not. But the SHOCK 2 and the others were designed very well in the ischemic substrate. And yet it showed there was no benefit. But clearly we all know anecdotally, like Venu said, that there is benefit. We see that. And in the morning, Dan himself was saying it's very easy to design trials which show no benefit. It is very difficult to design trials to show benefit. And I think that's where we all know there is some subset of patients where it benefits. We just not have been able to define that by trial to help the general community.
I want to point out, though, that in the SHOCK 2 trial, that there was almost a 12% crossover from control to balloon pump, which could have skewed the data.
I'd like to point out that the dominant LV unloading strategy currently in practice today is intra-aortic balloon pump. So if you have a patient who is in dire straits, an intra-aortic balloon pump is a very valuable adjunct vis-a-vis unloading.
If I could just make the practical point that the problem is other devices may be better, but they have more complications and the cost is infinitely higher. I've given talks about balloon pumps and people come up with other countries and say, well, thank you for discussing the balloon pump because I could like Impella all I want, but I can't afford that. That's the budget of the whole department. So balloon pump has some value in its least cost. The other part of it is as well that the Iabp SHOCK 2 trial only enrolled patients where people thought that there was some equipoise, and it was placed after the intervention, not before. So it's a population where you could think, well, it doesn't matter, put a balloon, don't put a balloon. It'll just like escape and everything else. People didn't put in patients where they thought they definitely would benefit. So, and lastly, the degree of patients with cardiac arrest skews things. And so we're trying to actually go back and do an analysis of Holger's trials with him to segregate them by sky class, because I think there is still some prospective class that you could figure out that actually do benefit, and others where they poison the well by not responding. As you look with Impress CP, Impella doesn't work any better than balloon in a direly ill population, does it?
I just want to make one editorial comment that I think in the context of meetings and discussing how to move things forward, I think at this time we shouldn't talk about cost effectiveness. I think in practice it's important, But what we need is to show something that works, and that will be cost effective. So, I mean, you talk about ECMO as being cheap, the device is cheap, but the care of an ECMO patient is infinitely more than the care of a patient with a balloon pump. So I think that when we talk about, again, moving the field forward, we should not at this moment be talking about cost effectiveness. That's just an opinion.
A couple of points. Not all AMI shock is same. We've talked about phenotypes again and again in this meeting, as well as the heterogeneity. An anterior MI large, more than 60% of myocyte loss during an MI with SIRS is different from an anterior MI without SIRS. So you can compare 50% of the patient who's having active CPR and then say balloon pump doesn't work. So I think if we are really going to use balloon pump for MI, we ought to take patients who benefit from balloon pump based on the hemodynamic profile.
I think this is what you're making, the same point that I tried to make earlier, that we have to phenotype the patients and enroll patients that are, with a phenotype that have the potential to benefit to get a positive trial.
I'd like to ask the speaker, thanks for bringing out that hyper-responder. It's been referred to, but actually getting to that paper wasn't that easy for me to do, so I'm really glad you showed that. When they assessed clinical benefit, I'd like you to talk just a little bit about that, and I wonder, was it the volume under the curve of the diastolic augmentation, was that part of the hyper-responder, or?
No. Yeah,
How did
so,
it go?
so actually, the way that they assess the clinical benefit, so the complete responders were simply patients that had improvement in mentation, so patients that had altered mentation, their mentation returned to baseline, or they had evidence of peripheral hypoperfusion, and that was reverse. So that was the two things that were looked at.
Well, specifically, were the legs blue and they turned red, or that can be very hard to,
I reread the appendix actually this morning in preparation for that, and it was fairly vague.
Right. And that's why you can't really look at retrospective.
It feels fuzzy to me, but.
Because it's gaming the system. So this is why it behooves people to do prospective studies, take that definition, do a prospective data collection. If the differences are that large, you don't need a lot of patients.
Yeah, I think
Because all that it conveys is those who got better lived, those who didn't get better died. That's all it said. So that's a very simple conclusion. At that, we'll stop. Andrew, thank you so much.